Trauma Blocking, Part 2, Dissociative Survival Mechanism. Dissociation is a broader disruption in the normally integrated functions of consciousness: memory, identity, emotion, perception, body awareness, or behavior. It exists on a spectrum from everyday experiences like highway hypnosis, deep absorption in a book, to more pronounced trauma-related forms. In trauma, it functions as a survival strategy that creates psychological distance from overwhelming experience. Key related mechanisms include the freeze, shutdown response, the dorsal vagal state. Stephen Porges' polyvagal theory describes the autonomic nervous system in a hierarchy. Ventral vagal, calm, social engagement, regulated state, and the default when safe. Sympathetic, fight or flight mobilization, when threat is perceived and action is possible. Dorsal vagal, the oldest branch, immobilization, freeze or collapse when threat feels inescapable. On simplypsychology.com, the freeze response: why trauma can leave you feeling stuck. The freeze response is a survival mechanism that can persist long after trauma. So you've probably heard of fight or flight, the twin stress response that mobilizes the body for action in the face of threat. But there's a third response that receives far less attention. So I read that. In freeze, sometimes called tonic immobility, the body becomes still, metabolic activity slows, heart rate may drop, pain perception can decrease, and awareness often disconnects. This is evolutionary, ancient, seen in prey animals, and automatic below conscious choice. These studies estimate tonic immobility occurs in 50 to 90% of sexual assault cases. One study found 70% among rape survivors. It is frequently misinterpreted as passive consent or lack of resistance, contributing to self-blame. Chronic or repeated activation can leave people feeling stuck, paralyzed, heavy, low energy, emotionally flat, or frozen in decision-making and daily initiation, even long after danger is past. It often cycles with hyperarousal in complex trauma. Emotional numbing. This is largely a dorsal vagal phenomena. The system dims or mutes emotional experience, especially positive effect or the full intensity of any feeling, to keep overwhelm manageable. It can feel like flatness, emptiness, detachment, or I know I should feel something but I don't. In complex or developmental trauma, it tends to be more pervasive and persistent than in single incident trauma. Dissociative amnesia and memory blocking. When experiences are too much, too fast, or too intense, the brain does not store them as coherent narratives. High-stress hormones impair the hippocampus, which organizes context and timeline, while the amygdala tags fragments with intense emotional and sensory charge. Memories may return as body sensations, flashes, or incomplete pieces rather than a full story. And state-dependent memory also plays a role. Material encoded under extreme stress may remain less accessible until similar psychological states return. And this is protective, allowing continued functioning contributes to gaps, hazy periods, or the sense that something is missing. Structural disassociation of the personality. Development by Onno van der Hart, Ellert Nijenhuis, and Kathy Steele. This theory views severe or chronic trauma, especially inescapable or relational, as dividing the personality along natural psychobiological fault lines of action and motivational systems. Two primary types of parts emerge. Apparently normal parts, ANPS, focused on daily life functioning, appears of normality and avoidance of trauma-related material. Emotional parts, fixated in traumatic experience, holding intense emotions, sensations, and defensive responses, so fight, flight, freeze, collapse, submission, etc. Levels of complexity range from primary 1 ANP plus 1 EP, more typical of simpler PTSD, to secondary and tertiary multiple parts associated with more severe, complex presentations. Disassociation is maintained by integrative deficits and phobias of trauma-related material, inner-directed avoidance. This framework helps explain oscillation between functioning and trauma-related states, as well as phenomena like identity shifts or profound compartmentalization. Psychotrauma. Body of knowledge of psychotraumatology. Theory of structural disassociation and trauma-related disassociation. The theory of structural disassociation, developed by Onno van der Hart, Ellert Nijenhuis, and Kathy Steele, provides a comprehensive framework for understanding disassociation as a fundamental consequence of trauma. This theory offers a detailed conceptualization of how traumatic experiences, particularly chronic or developmental trauma, fragments an individual's personality into distinct psychological structures or parts. The theory of structural disassociation, developed by Onno van der Hart, provides a comprehensive framework for understanding disassociation as a fundamental consequence of trauma. This theory offers a detailed conceptualization of how traumatic experiences, particularly chronic or developmental trauma, fragments an individual's personality into distinct psychological structures or parts. The theory of structural disassociation, developed by Onno van der Hart, provides a comprehensive framework for understanding disassociation as a fundamental consequence. I just made that. Now this theory, okay. Each with its functions, memories, and levels of awareness. So this theory offers detailed conceptualization of how traumatic experiences, particularly chronic or developmental trauma, fragment an individual's personality into distinct psychological structures or parts, each with its functions, memories, and levels of awareness. Structural disassociation primary concepts. Structural disassociation theory identifies two primary types of personality structures that emerge in response to trauma. Apparently normal parts, ANPS, parts responsible for daily functioning, maintaining an appearance of normality, and avoiding trauma-related memories or emotions. ANPs tend to function in everyday life, compartmentalizing trauma memories to preserve stability. Next is emotional parts, the EPs, trauma-bearing parts that remain fixated on traumatic events, storing unresolved emotional experiences, physical sensations, and intense defensive responses such as fight, flight, freeze, or collapse. In structural disassociation, trauma fragments the individual's integrated sense of self, creating a persistent internal division between these functionally distinct parts. Trauma survivors frequently shift between ANPs and EPs in response to internal triggers, external reminders, or interpersonal stresses, often without full awareness of these shifts. Levels of structural disassociation. Vanderhart proposed 3 progressive levels of structural disassociation, reflecting increasing severity and complexity of dissociative fragmentation. Primary structural disassociation, typically associated with single incident trauma or PTSD, involves one ANP and one EP. Individuals may experience episodic flashbacks, emotional numbing, and avoidance behaviors. Secondary structural disassociation, linked to chronic traumatization or complex PTSD, individuals exhibit multiple EPs. Emotional parts, each related to distinct trauma memories, emotions, or defenses, while maintaining one relatively coherent ANP, apparently normal parts. Symptoms may include emotional instability, identity disturbances, interpersonal difficulties, and chronic disassociation. Tertiary structural disassociation, characteristic of dissociative identity disorder, involving multiple ANPs, apparently normal parts, and multiple EPs, emotional parts. Personality fragmentation is profound, significantly impairing daily functioning and relational capacities. Neurobiology of structural disassociation. Neuroimaging research supports the concept of structural disassociation by demonstrating profound neural differences between disassociated personality states. For example, Reinders found distinct neural activation patterns when individuals with structural disassociation accessed the apparently normal parts, the AMPs, and the emotional parts, EPs, particularly in brain areas governing emotion, memory, and self-awareness, such as the amygdala, hippocampus, and the prefrontal cortex. These findings validate structural disassociation's theoretical claim that trauma-induced personality fragmentation involves substantial neurobiological changes, that merely psychological or symbolic phenomena. Trauma-related disassociation and clinical manifestations. Clinically, structural disassociation manifests through identity disturbances, shifts in sense of self, contradictory behaviors or attitudes, inconsistent memories or feelings of internal parts or voices. Emotional instability, sudden emotional shifts, intense emotional dysregulation, and difficulty modulating affective responses. Amnesia and memory gaps, missing personal history or daily events, reflecting compartmentalized memory across fragmented parts, somatic disassociation, physical numbing, chronic pain, medically unexplained symptoms, or a sense of disconnection from bodily sensations. Therapeutic approach approach to structural disassociation. The theory of structural disassociation recommends phase-oriented treatment, explicitly addressing personality fragmentation and fostering integration. So 1. Stabilization and symptom reduction initially focus on safety, emotional regulation, grounding techniques, and fostering internal collaboration among fragmented parts. Treatment of traumatic memories. Carefully placed therapeutic work integrating trauma memories, promoting co-consciousness, communication, and cooperation between ANPs and EPs, and personality integration and rehabilitation, gradually facilitating increased internal coherence, unified identity, and enhanced capacity for everyday life functioning. Therapies such as sensorimotor psychotherapy, internal family systems, EMDR, and relational psychoanalytic approaches effectively address structural disassociation by explicitly recognizing internal fragmentation and fostering increased integration and coherence. Clinical relevance and summary. The theory of structural disassociation profoundly enriches the conceptualization and treatment of trauma-related disorders, particularly complex trauma and dissociative condition. Understanding trauma through this lens supports compassionate, targeted interventions, specifically addressing underlying dissociative mechanisms. By addressing internal fragmentation directly, clinicians can facilitate more profound healing and more stable integrated trauma recovery outcomes. Neurobiology in brief. The amygdala threat detection often shows heightened reactivity. Prefrontal regions involved in regulation may go offline, or in the dissociative subtype of PTSD, show overmodulation, inhibition of limbic areas, emotional overmodulation leading to detachment rather than flooding. And the hippocampus function is disrupted under extreme stress, favoring fragmented, implicit, procedural, body-based and sensory in action, memory over coherent, autobiographical narrative. Networks involved in emotion regulation, salience, and self-referential processing show altered connectivity in dissociative presentations. These changes support the protective function by reducing awareness of pain or threat intensity while the body still registers psychological impact, physiological impact. PMC.gov, PubMed, Central. Emotion modulation in PTSD. So clinical and neurobiological evidence for a dissociative subtype. In abstract, in this article, the authors present evidence regarding a dissociative subtype of PTSD with clinical and neurobiological features that can be distinguished from non-dissociative PTSD. This dissociative subtype is characterized by overmodulation of effect, while the more common undermodulated type involves the predominance of re-experiencing and hyperarousal symptoms. This article focuses on the neural manifestations of the dissociative subtype in PTSD and compares it to those underlying the re-experiencing hyperaroused subtype. In a model that includes these two types of emotion dysregulation in PTSD is described. In this model, re-experiencing hyperarousal reactivity is viewed as a form of emotion dysregulation that involves emotional undermodulation mediated by failure of prefrontal inhibition of limbic regions. contrast, the dissociative subtype of PTSD is described as a form of emotion dysregulation that involves emotional overmodulation mediated by midline prefrontal inhibition of the same limbic regions. Both types of modulation are involved in a dynamic interplay and lead to alternating symptom profiles in PTSD. These findings have important implications for treatment of PTSD, including the need to assess patients with PTSD for dissociative symptoms and to incorporate the treatment of dissociated symptoms into stage-oriented trauma treatment. In this article, we present evidence that there is a specific dissociative subtype of post-traumatic stress disorder with neurobiological features that distinguish it from non-dissociative PTSD. Dissociation is a common feature of PTSD. It involves disruptions in and fragmentation of the usually integrated functions of consciousness, memory, identity, body awareness, and perception of the self and the environment. Although there are many ways to conceptualize dissociation, a useful heuristic is that dissociation involves detachment from the overwhelming emotional content of the experience during and in the immediate aftermath of trauma. Alterations in memory encoding and storage ensure leading to fragmentation and compartmentalization of memory and impairments in memory retrieval. Chronic psychological, sexual, and physical trauma, as well as emotional neglect, including parental psychological unavailability, have been etiologically related to dissociation. It has been hypothesized that such jarring experiences elicit dissociation, promoting a discontinuity of conscious experience and memory. Even though dissociative symptoms are often observed following exposure to chronic psychological trauma, acute traumatic events can also lead to dissociative experiences, often referred to as peritraumatic dissociation. For example, a number of studies of individuals experiencing danger or life threats have shown specific peritraumatic dissociative changes, including alterations in time sense, perception, attentional focus, and awareness of pain, among others. In addition, depersonalization has been described in a significant percentage of individuals facing acute life threats. Information related to the traumatic experiences is often differently encoded in these altered states, resulting in decreased access to information about the trauma once the person returns to his or her baseline state. This may give a subjective sense of compartmentalization of the trauma and lead to cognitive fragmentation or emotional detachment from the experience. The cost of this detachment may be avoidance of necessary cognitive and affecting processing of trauma in its aftermath. So acute dissociation responses to psychological trauma have been found to predict the development of chronic PTSD. Moreover, chronic pattern of dissociation in response to reminders of the original trauma and minor stressors develops in persons who experience acute dissociative responses to psychological trauma. This review will focus on the neurobiological and clinical features of chronic dissociation, defined as detachment states, depersonalization, derealization, and subjective distance from emotional experience for the purpose of this review in PTSD. Specifically, we will present evidence in favor of a dissociative subtype of PTSD with clinical and neurobiological features that can be distinguished distinguished from non-dissociative PTSD. The dissociative subtype is characterized by frequent overmodulation of effect, while the more common undermodulated type involves the predominance of the more commonly studied re-experiencing and hyperarousal symptoms. These findings have important implications for treatment of PTSD, including the need to assess patients with PTSD for dissociative symptoms and to incorporate the treatment of dissociative symptoms into stage-oriented trauma treatment. And failed versus excessive corticolimbic inhibition, a model of emotional under and overmodulation in PTSD. Neurobiological studies. Bremner has hypothesized that there may be two subtypes of acute trauma response that represent unique pathways to chronic stress-related psychopathology. One is primarily dissociative and the other predominantly intrusive and hyper-aroused. Data from neuroimaging studies have shown that two subtypes of response can persist in persons with chronic PTSD and are associated with distinct patterns of neural activation upon exposure to reminders of traumatic events. It should be noted that these response patterns are not completely distinct and that individual patients with PTSD may show both response patterns either simultaneously or at different time points. However, PTSD patients with prolonged traumatic experiences such as chronic childhood abuse or combat trauma often show a clinical syndrome that is characterized by chronic symptoms of dissociation, as opposed to patients who have suffered from more acute traumatic experiences. There has been investigations of the neuronal circuitry underlying re-experiencing hyperaroused versus dissociative responses in chronic PTSD that have used functional MRI and script-driven imagery. In this research paradigm, patients construct a narrative of their traumatic experience that is later read to them while they are in the scanner. Patients are instructed to recall the traumatic memory as vividly as possible during trauma scripts, and immediately afterward while the MRI scanner measures oxygen utilization in different brain regions. Results have shown that psychobiological responses to recalling traumatic experiences can differ significantly among patients with chronic PTSD. Approximately 70% of patients had the subjective experience of reliving their traumatic experience and showed an increase in heart rate while recalling the traumatic memory. The other 30% of PTSD subjects had a dissociative response. The latter predominantly involved subjective states of depersonalization and derealization with no significant concomitant increase in heart rate. The neural correlates of re-experiencing states and dissociative states, respectively, in PTSD show opposite patterns of brain activation in brain regions that are implicated in arousal modulation and emotional regulation. In particular, these differential patterns are found in the medial prefrontal cortex, the anterior cingulate cortex, and the limbic system. Emotional undermodulation, failure of corticolimbic inhibition. Patients with re-experiencing hyperaroused PTSD exhibit abnormally low activation in medial anterior brain regions that are implicated in arousal modulation and emotion regulation. More generally, including cortical modulation, increased activation of the limbic system, especially the amygdala, a brain structure that has been shown to play a key role in fear conditioning, has often been observed in PTSD patients after exposure to traumatic reminders, as well as to masked, fearful faces. We conceptualize this group of patients as experiencing emotional undermodulation. In response to traumatic memories, this type of response includes a subjective reliving experience of the traumatic events, such as a flashback. Re-experiencing hyperarousal reactivity can be viewed as a form of emotion dysregulation that involves emotional undermodulation mediated by failure of prefrontal inhibition of limbic regions. Further support for this model is found in studies that take a dimensional approach involving different symptom severities and associated neural activation patterns within each response subtype to individual differences in re-experiencing symptoms in response to trauma reminders. And this method examines correlations between severity of state, re-experiencing the two trauma scripts, and brain activity in regions associated with awareness and regulation of arousal and emotions. These studies have shown that severity of state re-experiencing was positively correlated with activation in the right anterior insula, a brain region that is involved in the neural representation of somatic aspects of emotional states and interoception of feeling states. State re-experiencing was negatively correlated with activation of the rostral portion of the anterior cingulate cortex, a brain region involved in arousal and emotional regulation. These findings are consistent with the phenomenology and clinical presentations of PTSD patients who exhibit pathological emotional and undermodulation during re-experiencing states, including a variety of negative emotional states and disassociated bodily experiences. Emotional overmodulation and excessive corticolimbic inhibition. In contrast to the re-experiencing hyper-aroused subtype, patients with dissociative PTSD exhibit abnormally high activation in brain regions involved in arousal modulation and emotional regulation, including the dorsal anterior cingulate cortex and the medial prefrontal cortex. The dissociative PTSD patients can be conceptualized as experiencing emotional overmodulation in response to exposure to traumatic memories. This can include subjective disengagement from the emotional content of the traumatic memory through depersonalization or derealization responses mediated by midline prefrontal inhibition of the limbic regions. Dimensionally, a dissociative response to trauma reminders is negatively correlated with right anterior insula activation and positively correlated with activation in the medial prefrontal cortex and dorsal anterior cingulate cortex. So in motor vehicle accidents related PTSD, the medial prefrontal cortex cluster that was positively correlated with state dissociative symptoms was negatively correlated with amygdala activity during script-driven imagery. This finding provides support for hypothesized hyperinhibition of limbic regions by medial prefrontal areas in states of pathological overmodulation. During dissociative states in response to trauma-related emotions. A recent study by Felmingham gives further support to the notion of distinct dissociative and non-dissociative reactions in PTSD based on the corticolimbic inhibition module. Using fMRI, these investigators examined the impact of dissociation on fear processing in two groups of PTSD patients, one with high and the other with low dissociation scores. Felmingham brain activation during the processing of consciously and non-consciously perceived fear stimuli. Patients with dissociative PTSD showed enhanced activation in the ventral prefrontal cortex during conscious fear processing relative to patients with non-dissociative PTSD, and the author suggests that these data support the theory that disassociation is a regulatory strategy invoked to cope with extreme arousal PTSD through hyper-inhibition of limbic regions. With this strategy most active during conscious processing of threat. A model of the two subtypes of PTSD is presented in Figure 1. Picture of emotional undermodulation and emotional overmodulation, so re-experiencing and disassociation. So in this model, re-experiencing of hyperarousal reactivity to traumatic reminders is viewed as a form of emotion dysregulation that involves emotional undermodulation mediated by failure of prefrontal inhibition of limbic regions. In contrast, the dissociated regions to traumatic reminders are described as a form of emotion dysregulation that involves emotional overmodulation mediated by midline prefrontal inhibitions of the same limbic regions. Additional evidence for hyperinhibition of the limbic system, including the amygdala during dissociative states, stems from the pain neurobiology literature. In a study examining healthy subjects, additional evidence for hyperinhibition of the limbic system, including the amygdala during dissociative states, stems from the pain neurobiology literature. In a study examining healthy subjects, Roeder found decreased amygdala activity. In response to painful stimulation during hypnosis-induced states of depersonalization. These findings are also consistent with amygdala deactivation in response to thermal pain stimuli in patients with PTSD, as well as with borderline personality disorder patients who generally show high levels of disassociation. A recent study revealed a similar pattern of increased mid-cingulate and insula activation in patients with borderline personality disorder and comorbid PTSD in conjunction with reduced pain sensitivity during script-induced dissociative states. Experimental studies examining emotional memory suppression in healthy subjects provide additional support for the model that dissociative PTSD involves hyperinhibition of limbic regions, with memory suppression associated with increased frontal and decreased hippocampal activity. Here, a complex neural network appeared to be involved actively in top-down memory suppression, including dorsolateral and ventrolateral prefrontal cortex, anterior cingulate cortex, the contiguous pre-supplementary motor area, a lateral premotor area in the rostral portion of the dorsal premotor cortex, and the intraparietal sulcus. Memory suppression was significantly associated with bilateral hippocampal inhibition. The authors conclude that their study provides a possible neurobiological model for suppression of unwanted memories consistent with the occurrence of dissociative amnesia. The aforementioned findings supporting the corticolimbic inhibition model of dissociative PTSD are consistent with the phenomenology and clinical presentation of patients with dissociative PTSD. Many of these patients require therapeutic approaches that help them associated emotions and bodily experiences. The corticolimbic inhibition model postulates that once a threshold of anxiety is reached, the medial prefrontal cortex inhibits emotional processing in limbic structures, the amygdala, which in turn leads to a dampening of sympathetic output and reduced emotional experiencing. Several studies in PTSD patients show that the prefrontal cortex has inhibitory influences on the emotional limbic system. These include PET studies showing a negative correlation between blood flow in the left ventromedial prefrontal cortex and the amygdala during emotional tasks, and negative correlations between medial prefrontal cortex and the amygdala during fear conditioning. Therefore, the low activation of medial prefrontal regions described in the re-experiencing hyperaroused PTSD subgroup is consistent with failed inhibition of limbic activity. This is associated with emotional undermodulation. In contrast, in the dissociative subgroup, increased activation of medial prefrontal structures is consistent with the notion of hyperinhibition of those same limbic regions. This results in states of pathological emotional overmodulation in response to trauma-related emotions. Successful emotional overmodulation appears to involve transient psychological disengagement from trauma-related information. This is marked by alterations in perception and consciousness as found in depersonalizations and derealization states and in dissociative amnesia. Summarizes these findings in each subtype of PTSD by contrasting brain regions involved in the re-experiencing hyperarousal undermodulation and dissociative overmodulation types of emotional dysregulation to trauma-related stimuli. This model resembles the signs and symptoms of response to a stressful life event that were originally described by Lindemann and Horowitz in their classic works on stress response syndromes. Horowitz suggested that the response to stressful life events were expressed in two predominant states. The first was an intrusive state characterized by intrusive feelings and compulsive action. The other was a state of denial marked by dissociative symptoms such as emotional numbing and constriction of ideation. So the core problem in PTSD from his point of view is under or overmodulation of effective response to traumatic memories. The emotion modulation system cannot adequately regulate effects of extreme traumatic input. And evidence of corticolimbic inhibition from dissociative disorders. Studies of depersonalization disorder provide further support for the corticolimbic model of dissociation. Hollander reported a case study of a patient with primary depersonalization disorder, studied using brain electrical activity mapping. They found left frontal overactivation indicated by increased interiorized alpha activity. They demonstrated with SPECT that this patient showed impaired perfusion in the left caudate and increased activity in posterior frontal areas. A subsequent investigation of a group of depersonalization disorder patients examined event-related fMRI to neutral, mild, and intensely happy and sad facial expressions with simultaneous measurements of skin reductant levels. Relative to healthy comparison subjects, depersonalization disorder patients show a decrease in subcortical limbic activity to increasing intense happy and sad facial expressions. Moreover, for both happy and sad facial expressions, depersonalization disorder patients, but not healthy subjects, exhibited negative correlations between skin conductance measures and activation in the bilateral dorsal prefrontal cortices. So these studies support the hypothesis that depersonalization disorder subjects exhibit increased prefrontal activity or decreased limbic activity, and this inhibition may result in the hypoimpulse emotionality frequently reported in these patients. Clinical studies. As described above, PTSD involves both under and overmodulation of affect, and individual patients with PTSD may show both response patterns either simultaneously or at different time points. However, PTSD patients with prolonged traumatic experiences, such as chronic childhood abuse or combat trauma, often exhibit a clinical syndrome that is characterized by chronic and frequent symptoms of disassociation, as opposed to patients who have suffered from more acute or single blow forms of trauma. TARE proposed two types of traumatic experiences. Type 1 trauma refers to traumatic conditions that results from single traumatic experiences and include predominantly full and vivid detailed memories, cognitive reappraisals, and misperceptions. In contrast, Type 2 trauma was proposed to be associated with long-standing or repeated exposure to extreme stressors and includes disassociation, denial and numbing, states of self-hypnosis, and rage. Further support for these findings comes from a study by Vander Kolk, who, as part of a DSM-4 field trial, examined a sample of 395 traumatized treatment-seeking subjects and 125 non-treatment-seeking subjects who had been exposed to traumatic experiences. Results showed that participants who had suffered early onset interpersonal abuse had significantly higher percentages of endorsements of dissociative symptoms than participants with late onset interpersonal abuse and disaster survivors. Moreover, subjects with dissociative symptoms include to suffer from disassociation even after they no longer met criteria for PTSD, thus suggesting severe chronic dissociative symptoms in response to early onset interpersonal violence. More recently, Ginsberg used signal detection analysis to identify high and low disassociation PTSD subgroups in a sample of 122 women who were seeking treatment for childhood sexual abuse. Specifically, 3 PTSD symptoms, including hypervigilance, sense of foreshortened future, and sleep difficulties, discriminated between the high and the low disassociation subgroups, while these prominent intrusive and hyperarousal symptoms in the dissociative subgroup may seem paradoxical. The disassociation may reflect a compensatory response to higher distress, perhaps mediated by alterations in thalamic activation. In addition, Zucker examined differences in dissociative symptoms in 155 subjects with PTSD versus subjects with PTSD who also met criteria for disorders of extreme stress not otherwise specified. The disorders of extreme stress not otherwise specified criteria were developed to characterize a population of traumatized individuals who suffer a complex form of PTSD, related multiple episodes of trauma over several developmental epochs, with symptoms of disassociation, emotion dysregulation, and somatization, altered relationships and attachments, and alterations in systems of meaning. Subjects with both PTSD and disorders of extreme stress, not otherwise specified, exhibited chronic symptoms of disassociation as evidenced by higher scores on the dissociative experiences scale than participants who were suffering from PTSD only. Moreover, studies in children have suggested that there may be 2 subtypes of acute trauma response that represent unique pathways to chronic stress-related psychopathology. One is predominantly intrusive and hyper-aroused, and the other disassociative. These studies therefore support the idea that trauma experienced earlier in life creates a significant dissociative component to later PTSD. Furthermore, it history of early life trauma is a predictor of the later development of PTSD in response to traumatic stressors. Studies in combat-related PTSD also point to a dissociative subtype of PTSD, taxometric analysis. In a sample of 316 Vietnam veterans, consistently revealed a taxon subgroup identified by scores that are discontinuous with a dimensional distribution of highly dissociative individuals. The dissociative subtypes of PTSD in this group was also associated with more severe PTSD. Putnam examined whether mean dissociation scores are measured by the Dissociative Experiences Scale resulted from uniform distributions of scores in a group of 166 predominantly combat-related PTSD patients. Results show that the diagnostic group's mean dissociative experiences scale scores were a function of the proportion of subjects within the group who were high dissociators, thus suggesting the existence of a distinct dissociative subtype. An earlier study of Vietnam veterans has also reported that chronic dissociative symptoms are an important element of long-term psychological responses to combat trauma, which is often repetitive in nature. So, treatment and research implications. Exposure-based treatments for PTSD have the strongest empirical support and involve repeated imaginal and in vivo exposure to trauma-related stimuli. In order for exposure-based treatments to be successful, patients must be able to fully emotionally engage with the trauma-related information. Typically, patients are asked to recall details of their traumatic experience while describing them in the present tense. Exposures are designed to overcome avoidance of such stimuli by providing a safe context in which patients can fully engage with both trauma-related and corrective safety information. In this way, exposure treatment is designed to overcome and reduce avoidance symptoms, enhance affect management, and facilitate cognitive restructuring of trauma-related memories. In turn, this should bring about the reduction of re-experiencing and hyperarousal systems and ultimately elimination of the disorder itself. So exposure treatments should be used with caution in patients with significant emotional overmodulation, such as dissociative and numbing symptoms. Fola and colleagues have suggested that such symptoms can prevent emotional engagement with trauma-related information and thereby reduce treatment effectiveness. A recent study suggests that levels of dissociation are an important negative predictor of psychotherapy outcomes in patients with borderline personality disorder, a disorder that has often been associated with childhood abuse. Also, dissociative symptoms of block emotional learning in a classical conditioning paradigm. It has been shown that patients with borderline personality disorder and high levels of dissociation did not show differences in skin conductance and arousal between conditioned stimuli that were paired with an adversive sound and unpaired conditioned stimuli during acquisition and early extinction. While borderline patients with low levels of dissociation and healthy subjects did, these results suggest that emotional amygdala-based learning processes appear to be inhibited by state dissociation through alteration of acquisition and extinction processes. So it is crucial before commencing exposure-based treatments to assess levels of dissociative psychopathology and provide interventions to reduce dissociative symptomatic responses to trauma-related stimuli. Failure to do so can lead to an actual increase in PTSD and related symptoms, including dissociation, emotional dysregulation, and an increase in the patient's overall distress and functional impairments. And recognition of such dissociative complexity of symptoms of patients with chronic PTSD related to childhood abuse, Poiter and colleagues developed an integrative and empirically supported phase-based intervention for long-term child abuse-related PTSD. Their model accounts for the significant dissociative symptoms frequently associated with repeated childhood maltreatment. Their approach delivers a stage-oriented model that uses skills training and emotion regulation before engaging in exposure-based therapy. Poiter provide data to support the idea that patients must develop mood regulation and grounding skills, identify and modify disordered attachment schemas learned in childhood, and work on competence in social interactions. Future treatment outcome research will need to focus on complex childhood abuse-related PTSD and other types of PTSD that have shown to have considerable dissociative symptoms. This will help recognize and further develop interventions that are most effective in managing dissociative symptoms and allow them to be optimally timed in a phase-oriented treatment model. In terms of research, the results described in this review suggest that careful attention must be paid to the differential responses of under and overmodulation of effect often observed in PTSD. Grouping all PTSD patients regardless of their different symptom patterns in the same diagnostic category will hinder our understanding of post-traumatic psychopathology. Classification of different PTSD subtypes will enable a more careful analysis of differential responses to psychological trauma and eventually lead to a more sophisticated understanding of the neurobiology and treatment of PTSD. Future neurobiological research will have to closely examine the relationship between the medial, prefrontal, and amygdala circuitry during states of under and overmodulation of effect and brain activation of other brain regions previously proposed as implicated in dissociative PTSD, including the thalamus, superior colliculus, and periaqueductal gray, as well as brainstem structures. The latter will show a more detailed understanding of the association between higher and lower brain structures during re-experiencing and dissociative states in this disorder. Both neurobiological and clinical research have shown that PTSD has two subtypes: re-experiencing, hyperaroused, and dissociative. These different trauma response subtypes can be viewed as different extremes of emotional dysregulation. The first involves undermodulation and the second overmodulation to trauma-related emotional and somatosensory information. Each response type appears to have distinct CNS correlates, and each response type has been correlated with specific neural activity in brain regions responsible for arousal modulation and emotion regulation, including the medial prefrontal cortex and the anterior cingulate cortex. Findings of lower activation of medial prefrontal regions in the re-experiencing hyperaroused subtype is consistent with failed inhibition of limbic reactivity and is associated with hyperaroused emotional undermodulation. In the dissociative subtype, increased activation of medial prefrontal structures is consistent with hyper-inhibition of those same limbic regions in states of pathological emotional overmodulation. These findings have important implications for assessment and treatment of PTSD, including the need to assess patients with PTSD for dissociative symptoms and to incorporate the treatment of dissociative symptoms into a stage-oriented trauma treatment model. They also suggest that grouping all PTSD patients for the purposes of research, regardless of their different symptom patterns in the same diagnostic category, may hamper our understanding of post-trauma psychopathology. Functional neuroimaging may be useful in treatment selection and monitoring of outcome of these different post-traumatic responses.